Good afternoon. Thank you, Dr. Prasad and the organizing committee for inviting me here to give this talk. So today we are going to look in depth about molecular mechanisms that kind of plays a role in progression of acute kidney injury to chronic kidney disease. So for a post-lunch afternoon session, it's going to be a lot of molecular stuff. I'm giving heads up and warning, and I'll try to keep it interesting as we walk through this. So little bit about acute kidney injury. AKI affects 30-60% of critically ill patients, and it's associated with acute mortality and morbidity. And again, because of the long-term impact on renal function, including chronic kidney disease, and risk of recurrent AKI and increased risk of cardiovascular complications. So long-term mortality is increased even after a single episode of acute kidney injury. So therefore, prevention, early recognition and prevention of acute kidney injury is really important. And unfortunately, we have not made much progress. There are very limited interventions that we can use in our patients to prevent and treat AKI. And these are generally limited to, optimizing hemodynamic status, generally with fluids and avoidance of nephrotoxic medication. And also search for a specific pharmacological treatment is hampered by late diagnosis and complex and incompletely elucidated pathophysiology. So in that sense, like now, various classifications are there. I'm just for the sake of giving you a little bit background, here you all know this, a patient at risk of AKI, for example, somebody with a chronic kidney disease or congestive heart failure. And then we have this subclinical AKI where there is an increase in biomarker, but you have not seen an increase in creatinine or a drop in urine output. And then AKI stage 1, stage 2, and stage 3. And if this reduced kidney function continues beyond a week, up to 3 months, now we have this period called acute kidney disease. Beyond 3 months, if the renal function dysfunction persists, then it becomes a chronic kidney disease. So various things have been discovered in the last few years, and people have come out with a clinical risk score, which can be useful in predicting who is going to get acute kidney injury. For example, this is useful in cardiac surgery setting. You can plug in certain factors and that can give you some information. Usually biomarkers are in a later stage of acute kidney injury, which is when it is useful, although I'm going to show you some data where biomarkers are becoming available where you can actually predict the risk of acute kidney injury. And then this e-alert, some of it I think Dr. Jha will cover in his talk, and real-time prediction models with artificial intelligence coming into picture. So this is again a summary of the same thing where we talk about acute kidney injury, and then there is a big acute kidney disease here, and there is an overlap, and then it evolves into chronic kidney disease, primarily determined by the duration of persistence of low kidney function. And so usually, many patients may not have a biopsy, and if they do, that will help. But in addition, you can look for markers of kidney damage like albuminuria, and even in patients evolving from AKI to CKD, albuminuria can be a very powerful predictor. So generally, when we go by clinical factors, there are a lot of studies that are available. What I try to do is to pull some recent studies to see if there are some new pieces of clinical data that could be helpful in our day-to-day rounds, when we see patients. So, for example, in cardiopulmonary bypass, we all know age is an important factor, CKD, diabetes, all those factors are there. But then this recent paper in a small sample size, but again showed if presence of right ventricular dysfunction and diastolic dysfunction are important disease predictors. So then, as I mentioned earlier, this recent paper published in Lancet actually have discovered a biomarker which can be measured pre-operatively. It's called DKK3 or creatinine. And this can actually predict who are the patients who are going to have an acute kidney injury with a, it's a sample size of 733 patients. And pretty significantly, it can predict the risk of acute kidney injury. So then there are like other newer biomarkers, TIM2, IGF-BP7, NGAL, many of you are aware. And the standard clinical practice, we use fractional excretion of sodium, fractional excretion of urea, proteinuria, and all that. But then there is also this a kinetic EGFR, which is calculated based on changes in creatinine. So this is the formula for calculating kinetic EGFR, where you measure serum creatinine at 2 different time points, and then you plug into this equation, and that can actually give you a better estimate of what is happening to the kidney. So then going to some novel biomarkers, what I did is that I took those, there are like hundreds of thousands of articles for biomarkers in AKI. So then I was going through the literature. I just picked up those where there are repeated kind of data from multiple centers showing that it is showing promise. So CCL14 is one such marker where they've shown that it's a novel one, where they've shown that there is a pretty good prediction for acute kidney injury, and particularly with the cutoff, which is more than 13, it's a very, very good marker for predicting persistent acute kidney injury. So essentially, persistent acute kidney injury is when acute kidney injury persists for more than 3 days. So, so this is something it could be used. So now, with this background, now let us start thinking about pathophysiology of acute kidney injury. So we all know that there is a tubular epithelial necrosis, and we know that there are immune inflammatory cell infiltrate, and there are like a lot of other novel mechanisms. Right? Mitochondrial dysfunction is something we all know. It's a part of what happens in the kidney. But then there are like newer things, like you must have heard this work from Samir Parikh about the deficiency of NAD+. He had a fantastic paper where a small clinical trial as well, where he showed that this could actually, deficiency of NAD could play a role in acute kidney injury. But then there are a lot of other very interesting mechanisms that are evolving, particularly the cell cycle arrest. The work with cell cycle arrest is very old. Dr. Bonventre's group has published on this more than 20 years ago. But then new pieces of information are evolving in the area of cell cycle arrest. And then ferroptosis, this is something area very close to my heart, because some of the work I did was in iron and acute kidney injury. And I'm very gratified to see that a lot of work, very, very good, coming out, showing relevance of ferroptosis in acute kidney injury and progression to chronic kidney disease. So now that being said, so let us step back. So we see acute kidney injury, and then patients that are typically hypovolemic, and let's say they have a diarrhea or gastroenteritis. That is one set of patient we see on our rounds. And then we go to the next bed, and then here we have a patient who underwent a abdominal aortic aneurysm surgery. And then there was clamping, cross clamping of aorta, and then there's a renal ischemia, and then patient has got acute kidney injury. So here, on a routine clinical practice, see, both these patients have elevated creatinine. Both these patients have a drop in urine output. And then the standard markers, we may use creatinine. Best case scenario, we may measure like NGAL. And then we say that, okay, patient has got acute kidney injury, whether you diagnose it 12 hours later or 48 hours later. And then treatment, wait and watch, give Lasix, urine output picks up or not. And then dialysis becomes indicated, start dialysis. I mean, that is where we are with our clinical practice of acute kidney injury. And we treat both these patients identical. But what it turns out that there are entirely different things that are happening in the kidney, although both seem to have a reduced blood flow causing a tubular necrosis and acute kidney injury. So this is very important to understand. So all AKI, although they may look like it's all ATN, it's not the same. See, right now we think about ATN and acute interstitial nephritis as separate. We know that acute glomerulonephritis and interstitial nephritis is separate. But when it comes to ATN, we think like ATN is all one and same. When we think about AKI, we think about ATN, but ATN is not all one and the same. It's different. So how do we know this? So in this paper, what they did is they depleted volume to cause a volume hypovolemic AKI. And then in another group of mice, they induced a renal ischemia by clamping the artery to cause like acute kidney injury. And then they went and looked at very deep transcriptome changes in different parts of the kidney. That's what you're seeing. Look at what you're seeing, the Venn diagram here. There is very little overlap in terms of the changes in the genes and RNA that you're seeing between these two group of kidneys. So AKI is not all one as we think. So again, here showing some of the heat maps, you can look at there is nothing that's comparable between the two. It's all red here. And then they looked at various signals here. And here, in volume hypovolemic AKI, you're seeing more of metabolic kind of changes here. But whereas in inflammatory acute kidney injury, you're seeing a lot of coagulation and inflammatory pathways that are like different here. So not only ATN, and let's say that we have patients with a sepsis presenting with acute kidney injury. It turns out patients with sepsis, they have like very different phenotypes. So this is a fantastic paper published in Chest and then a few others. Now they phenotype sepsis into 4 different phenotypes. So the patients with the delta phenotype of sepsis are the ones who get acute kidney injury. What is the delta phenotype of sepsis? These are the patients who are hyperinflammatory. They got like a lot of activation of coagulation markers. Inflammatory markers are very, very high in these patients. Many of them have underlying, for example, chronic liver disease. They belong to the delta phenotype. So when you're seeing somebody with a sepsis, look at these phenotypes to understand what is the risk of acute kidney injury. You can literally put them into these categories and then say that this is the subset of patients who is going to be most likely to develop acute kidney injury. Right? So this is all based on clinical observation itself. There is so much of it. So likewise, so far what we have seen is not all ATN is not identical. Within ATN, there is a huge differences. All sepsis is not the same. There are like 4 different phenotypes at least that we know of. Now looking at cell death. So when we talk about acute tubular necrosis, we used to talk only about apoptosis and necrosis. So now we know that there are varied types of cell deaths that happen in kidney injury. So now apoptosis is when there's a caspase dependent process. And the key thing that I want you to remember is when there is apoptosis, the plasma membrane does not rupture. It does not rupture. So it does not lead to activation of the inflammatory cells. So it's a non-inflammatory kind of a thing, apoptosis is. It does not play an important role in acute kidney injury. That is something for the trainees here, very important to remember. Apoptosis does not play a very important role in the pathogenesis of acute kidney injury. So now if you leave apoptosis aside, now people have thrown away the term necrosis. Now we talk about like 2 important types of cell death that happens in a kidney that is undergoing ATN. The first one is what is called as necroptosis. The second one is called ferroptosis. Ferro is iron, so it's an iron-mediated cell death. Necroptosis. So both these processes have very well-defined molecular pathways. And again, what you can see is in both these processes, unlike apoptosis, there is rupture of plasma membrane, and it leads to activation of inflammatory cells. So you will see infiltration of the immune cells like macrophages, lymphocytes, they all come into the kidney. So this is the reason why these kidneys do not recover completely. They progress on to develop something chronic. That's the hypothesis. I'm going to show you more papers. So this is the 3 types of cell that we spoke about: ferroptosis, apoptosis, and necroptosis. Very complex molecular mechanisms. And here, you see hepcidin. This is the work that our lab have originally showed to be protective in acute kidney injury and in other models of like kidney injury by limiting iron that's available in the peripheral blood. But then a lot of other excellent work have really studied ferroptosis closely. Now we have like small molecules that can inhibit ferroptosis and have been shown to benefit acute kidney injury. So this is apoptosis, and this is what is called necroptosis. If you have to remember something within this complex cascade, I would suggest remember RIPK3, RIPK1, and MLKL. So those are the three things you need to remember in necroptosis. So that is how like necroptosis happen in the cell. So now it's not that just the epithelial cells are dying. As the epithelial cells in the kidney is dying, I want you to visualize a kidney that is undergoing ischemia. This is your patient who is post-operative after abdominal aortic aneurysm after a clamping. So you are seeing him at hour 3 after surgery. He's not making much urine. So what is happening is that those cells are dying by necroptosis. There is death by ferroptosis. And then these cells are releasing extracellular vesicles, which is going and attacking the healthy epithelial cell, which is present in the kidney. So this is called as propagation of kidney injury. So you need to have one insult, and then that one insult leads to a propagation of wave of death. That's what it is called. That is what leads to worsening of kidney function, although the insult is not persisting anymore. So now this is a very important concept that has evolved over a series of papers that has been published. The cells are called inflammatory proximal tubular epithelial cell. Essentially, what they've shown is the proximal tubular epithelial cell, when the AKI persists, then over a period of like when we have like acute kidney disease, AKI to become AKD, then these epithelial cells, they start expressing this markers called VCAM1 and SOX9. And essentially, what was very interesting is that like these are the cells that lead to persistent dysfunction of the kidney. So these inflammatory proximal tubular cells, now rather than being non-inflammatory epithelial cell, the cell itself changes the phenotype. It becomes an injury inflammatory proximal tubular cells. And what this study showed is that like these cells have high expression of ferroptosis markers. And when they gave the small molecule LIP1, then they were able to show that they were able to reduce this persistent abnormal cells in the kidney. So essentially, this is a paper just published recently to show that you can inhibit ferroptosis and prevent AKI becoming AKD and becoming chronic kidney disease. So this is again the same thing I'm showing here to show that you can show the benefit over a long period of time. So these are called as damage associated proximal tubular cells. These are the healthy proximal tubular cells in the kidney. And then there is this fraction of cells that leads to progression of the chronic kidney disease. So you can inhibit them, and then you can show that there is a benefit that happens. And not only ferroptosis, there are like, necroptosis and inflammatory markers like TNF alpha. And there is another protein called Indian hedgehog. Here they show that, you can inhibit that by giving, genetic knockout of the animals. You protect the kidney from fibrosis. And this is a, animal model of ureteric obstruction. And also what they show is that like patients who have an elevated level of Indian hedgehog, then they seem to have a worsening GFR in the long term. So this is another biomarkers that could be helpful. You can measure Indian hedgehog in the plasma, and then say that, let's say that you see a patient 1 month after AKI, you can measure the Indian hedgehog levels in the blood. If it is persistently elevated, he is likely to progress to chronic kidney disease. So then these cells are also called as scatter cells. The cells that I told you as injury inflammatory proximal tubular cells, they are also called as scatter cells. So this is one paper, I'm just showing it here because, it's not like all evidence suggests that these cells are bad. There's one paper in a model of renal artery stenosis showed that it could actually have some beneficial roles. I don't know what to make of this. There's the only odd paper out there which gives a contrary evidence. So then in these cells, there are a lot of genetic changes that happen, and they looked at various markers. And so this state of epithelial cell, it's called as failed repair. So these cells are not able to repair, and they get better. So the next two sets of data I'm going to show is very interesting. I want you to pay attention to these two interesting pieces of data. So far we have looked at ferroptosis. We have looked at a set of proximal tubular cells which are not recovering, which are inflamed, which is causing chronic kidney disease. But then there is an idea called polyploidy. Polyploidy is like, where multinucleated kind of cells, where the cells have thing. So what they showed is that like in this paper, when you have polyploidy, it's controlled by a factor called YAP1. And this was published very recently in Nature Communications. And very interestingly, when you induce polyploidy, you protect from acute kidney injury, but you have worse chronic kidney disease. So this is a very important concept to remember. So these animals are protected from acute kidney injury, but they have worse chronic kidney disease. Okay, so this is one set of data. So this is the previous one. So again, they have like worse fibrosis, as you can see here. When you knock out the polyploidy is induced, because when you have SAV1 knockout, there is more polyploidy, and they get like more fibrosis. All the blue areas are more fibrosis. So normally, what you would have thought is, when you have a protection from acute kidney injury, you would think that there is less injury, therefore there will be less fibrosis. But rather, what you saw in this paper is that like it's not necessarily true. There is not a linear correlation between a protection from acute kidney injury and protection from chronic kidney disease. Okay, now go to the second paper. So this paper is something where they deleted a gene that's important for renal development. PAX2, PAX8 genes, they're important in the formation of the renal tubules and everything, when the kidneys form. So they just knocked out those genes in the tubules of the kidney. And then what they did is, then they induced ischemia, and then they looked at what happens acutely and what happens chronically. What was shocking is that these kidneys, they had like increased injury, acute injury, but they had like less fibrosis in the long term. It's the opposite of the last paper I showed you. So the last paper, we saw that there is more injury, there is protection from injury, but there is more fibrosis. Despite protection from acute injury, there is more fibrosis. This paper shows there is more injury, but those mice with the more early injury changes have protection from fibrosis. Okay, so this is like, this completely throws out the hypothesis that there is a linear correlation between more injury to the kidney and more fibrosis. That's not true. So then the authors here, they went ahead and separated these cells, and they show that essentially you induce a little bit injury to the kidney cells. Then those cells, they get prepped and they're ready to deal with a bigger challenge. It's like the example I can give is a spoiled kid. A kid that has been challenged a little bit is prepared for the worst. I mean, even an adult. Same thing happens in the kidney tubular epithelial cells. So people used to call this as a preconditioning kind of a thing. I mean, this is fascinating. So then there are like novel mechanisms, like, there is a whole thing called TASCC, which is a component that has like involved in like, cell cycle arrest, and which is associated with cyclin G1. And that turns out to be very important. And if you are able to knock this out in the proximal tubule, then you reduce kidney fibrosis in mice with a chronic kidney disease. So then there is also some data about intracellular HMGB1. See, HMGB1 is actually one of those danger-associated molecules, right? And a lot of studies have previously been done where they actually gave antibodies or other kind of chemical inhibitors to neutralize HMGB1. And the idea was that it will protect from chronic kidney disease. It will prevent acute kidney injury and protect from chronic kidney disease. And the data has been negative. It has been all over the place, and essentially people gave up. But here in this paper, what they have actually shown is HMGB1 is present inside the cell. It's called tubular intracellular HMGB1. If you're able to specifically delete the tubular HMGB1, then you're able to protect from AKI becoming chronic kidney disease. So this is another type of a new thing which is been published recently, where we know the distinction between extracellular and intracellular HMGB1. So now we have so far looked at various molecular pathways, various types of cell death, and cell cycle, danger molecules, and also we looked at the discorrelation between severity of acute kidney injury, and chronic kidney disease. So those are the 4 or 5 things we have seen so far. So now that comes a very another important concept, which is nephron endowment and risk of progression of AKI to chronic kidney disease. See, there is a lot of work, on nephron endowment, and generally the thought is that these are people who may have increased risk of chronic kidney disease. But this paper is a very, very nice paper to actually systematically address that. So the glial-derived neurotropic factor and its signaling through RET is very important in nephron development. So what they did, authors, is that if you're going to really delete RET, then those mice won't develop. They won't survive. So now they came out with a very interesting innovation here. So they created a mouse with a floxed RET allele that's engineered with a single amino acid substitution. So what it does is that now the RET protein is more sensitive to a chemical. So now they can actually go and give a chemical to modulate the level of RET. And so essentially you're creating a very similar kind of a thing. And what they actually showed is that as you see in the picture, the nephron numbers are less in the NAPP1, which is the mutant mice treated with a drug. So essentially in this setting, they took those mice and with a low nephron endowment, and then they looked at, just followed them. That's one set of experiments. And the second set of experiments is that in those mice with the low nephron endowment, they gave neonatal gentamicin exposure, and so it's a nephrotoxin, and then it causes severe injury and incomplete repair. In both these model systems, they went on to show that there is worse chronic kidney disease as these mice get older. And also after an acute kidney injury, these mice go on to develop accelerated chronic kidney disease. So this is an excellent experimental model to really show that low nephron endowment is a risk factor for AKI progressing to chronic kidney disease, right? So next time, for trainees, when you see a patient, make sure you take a birth history of the patient, if it is available, right? So that could have some relevance to their adult risk of AKI progressing to chronic kidney disease. So now this is another model they've used. We didn't have a good model to study cardiorenal syndrome. So here authors have created a model of a CPR, cardiac arrest. So essentially what they did is that they took mice and then they actually intubated the mice, gave anesthesia with isoflurane, and then they induced cardiac arrest. And they left the mice for 8 minutes, and then they did a CPR, and they were able to rescue about 75% of the mice. So now they are survivors of cardiac arrest, these mice. And now, so it's a model which is developed and published in 2019. So it's a good model to study, what happens after cardiac surgery. So then they looked at this is a complex system, what they developed and how AKI kind of develops and what percentage of patients, mice develop chronic kidney disease. They're followed up to 7 weeks here, They didn't have a follow-up after 7 weeks, but 7 weeks is a pretty good length of time. And as you can see that very significant subset of these mice, they go on to develop chronic kidney disease. But what is very interesting here is this is a GFR. So if you look at these are sham, which are control mice, and these are mice that underwent the cardiac arrest followed by resuscitation. It's at 1 week. As expected, at 1 week, there is acute kidney injury. There is less GFR. And then if you follow them for 2 weeks, at 2 weeks, there is a recovery of GFR, pretty good recovery of GFR, as you can see, compared to the sham level here. But despite a recovery in GFR, you look at the kidney, there is significant fibrosis. So this is another very important lesson to keep in mind. So we see patients with acute kidney injury where the creatinine goes up from 0.8 to 2.4, and then we give fluids or whatever interventions we do, creatinine falls back to 1.2. Then, if you're a little bit, nephrology team is a little bit more patient, they'll say, okay, follow for 1 more day. And then they follow, and then the creatinine comes down to 0.9, and then we'll say we are signing off. Okay. But remember, we are signing off of acute kidney injury with patient developing fibrosis in the kidney. So this is the piece of data that really shows you that you may have a complete clinical recovery of acute kidney injury, but you may have a histopathology which is actually showing progression to fibrosis. So now just think about it. If you have repeated episodes of acute kidney injury, the patient has ventricular fibrillation, right? I mean, his AICD didn't fire, and then he has another episode of cardiac arrest, or patient gets perforated diverticulitis, and then he comes in with sepsis as another event, like all within a period of 3 to 6 months, or like a 9 months or a year. Every one of them is going to cause this kind of leave this residual fibrosis in the kidney, which leads to the reduction in the GFR that you're seeing. So this is a beautiful piece of paper, really showing that phenomenon that is happening. So this is the point I want to mention, that what is happening is in this kidneys, which is worsening of the fibrosis, as you see here, with all the straining for fibrillin and smooth muscle actin, but there is also significant worsening of inflammation. These are macrophages, and then, inflammatory macrophages, INOS positive, and then a lot of lymphocytes also present in the kidney. So we don't biopsy the kidney. How many times we have biopsied a kidney which has recovered from AKI? I would say 0. So this is what is happening in the kidney, so this at least something to keep in mind. So anyway, so the consequence of the tubular, all the necrosis, necroptosis, ferroptosis, and all that we saw, and then subsequently it leads to an inflammatory process that is happening, which in turn secretes various factors, and then there is worsening of fibrosis. That is what we are seeing in this kidney. So now, normally when we think about inflammatory cells and persistence or worsening of chronic kidney disease, we tend to think about macrophages very commonly. Maybe we'll think about dendritic cells. That is one of my laboratory work during my fellowship. We think about a lot of work on lymphocytes. But these recent data actually show a very important role for natural killer cells in the kidney. So this is the third most common subset of inflammatory cells. They isolated in the kidney after acute cardiorenal syndrome. So something to think about. And there's a beautiful paper here. What they showed is that NK cell infiltration preceded expansion of the fibroblast in the kidney. And not only that, they went on to show that if they are able to administer granzyme A, which is actually a mediator that comes from the natural killer cells, it actually stimulates fibroblasts to proliferate. And then they went on to show that if you block granzyme A signaling in mice, you're able to attenuate fibrosis development in the kidney. So now we have a new target to think about. Maybe we need to inhibit granzyme A or natural killer cells. So there are many, many other factors. For the brevity of time, just to keep the focus. And so I'm not covering the roles of uremic toxins, gut microbes, brain-kidney axis, stem cell therapy. There may be myriad of other kind of hypotheses and factors which may be relevant in AKI to CKD progression. So now we saw a lot of mice data, and then we fill that with some of the relevance for our clinical practice. But then, it wouldn't be good if I didn't bring any human data. Fortunately, we have some human data that just got published in Nature in 2023. So here they took a comprehensive atlas of both healthy and injured renal cell states. And it's more than 400,000 single cell nuclei data gathered from 3 major consortia: Human Biomolecular Atlas Program, KPMP, and then Human Cell Atlas. And then healthy reference were from 45 individuals who were healthy. And then also they had biopsy of 48 patients suffering from acute kidney injury or chronic kidney disease. And then they did in-depth transcriptomes and omics, and then multiple immunofluorescence studies to really define the intricate cellular status of what is happening in the kidney, human kidney, after acute kidney injury. So in that, they saw a lot of very interesting thing, but one thing which really was a surprise. It turns out one of the signature which gets activated in acute kidney injury is not just proximal tubular cells turning inflammatory. It's actually the thick ascending limb of loop of Henle. So this is something loop of Henle signature for the first time, right? So this is why, you can't apply all the mice data to human, So there is a difference, Mice data does give a clue. You have to do human research. And so essentially they have found that there is a maladaptive change that's happening in the loop of Henle. And they found specific factors like, TRAP2B in the mid-repair stages of the distal tubules, So essentially, the thick ascending limb of loop of Henle signatures were significantly associated with progression of kidney disease. So now, if anybody ask you a question, what are all the factors in the kidney after acute kidney injury that are important for progression to chronic kidney disease? You must say that proximal tubular cells turning inflammatory. Now we have this paper from Nature 2023, which clearly shows a role for loop of Henle in human kidney biopsies turning pro-inflammatory. And then we have lots of data on varied type of inflammatory cells playing a very important role. And of course, fibroblast. But eventually the loss of podocytes and glomerulosclerosis and all that happens in the kidney. So this is the thing, this is the essay question for the DM graduates here, for the molecular pathogenesis of acute kidney injury, and so something to keep in mind. So this is again showing that pictorially the importance of loop of Henle. So now a little bit about therapy. Last 3-4 slides I have about 4 minutes. So essentially, can you inhibit ferroptosis to prevent renal fibrosis? That's the next question. And then it turns out rosiglitazone, Avandia, which is no more in use or very little in use, is a very powerful inhibitor of ferroptosis. So in this study, what they did is they went ahead and used this in a mice model, and they actually show that the amount of fibrosis is reduced after unilateral ureteric obstruction when they gave this mice Avandia. And they also show that there is reduction in ferroptosis markers, which they measured here. So now the second interesting preclinical thing that is coming up is inhibition of endothelin A. Here they used the endothelin A inhibitor and then went on to show that actually, this is in human AKI. So what they did is that they took human AKI and they showed that the levels of endothelin 1 in both plasma and urine fractional excretion is pretty high in acute kidney injury. And then they went to animal model to really show that if you're able to inhibit endothelin endothelin A, then you have the orange one, you're able to actually protect the kidney, cortex medulla, you reduce inflammation and improve the microvessel density in the kidney. So this may be something that you may end up seeing. So there is actual clinical data. Do you have any clinical trial for preventing progression of AKI to chronic kidney disease? Nothing. But this is the only database type of data that's available from veteran study, where they actually showed that if you're able to start SGLT2 inhibitor after the onset of AKI, and here retrospectively they are looking at it, those who started SGLT2 inhibitor after AKI versus those who didn't, and they went on to show that there is a significant reduced hazard risk in various models that they tested. Those who started SGLT2 inhibitor after an episode of AKI, they had reduced chronic kidney disease. So if there is any little bit evidence for any agent based on human data, this is the only one. So now you may ask a question. We spoke about a lot of biomarkers to predict AKI, but are there any biomarkers that can say that my patient is unlikely to get acute kidney injury? So these are negative biomarkers of acute kidney injury. It turns out there are 2 biomarkers that you can test that, if high, would say that the kidney of your patient is likely to be protected from acute kidney injury. So these are called negative biomarkers. And the 2 are essentially uromodulin and, very surprisingly, epithelial growth factor. So if a patient has high urine epithelial growth factor, then there is a very significant reduction in the risk of postoperative acute kidney injury. So again, these are things that need to be replicated, tested in large samples and so on and so forth. But I just want you to think about this. When you talk about biomarkers, always think about negative biomarkers for acute kidney injury and CKD progression. This is the paper which actually showed that if the urine epithelial growth factor is high, then the hazard ratio for CKD progression is actually 0.83. So one little bit snippet that we normally think about AKI, CKD progression, dialysis, cardiovascular risk. But this paper, which was published recently, has actually shown that people who have AKI, who progress to AKD and chronic kidney disease, have increased infection risk. Because remember, when you have a progression of acute kidney injury to chronic kidney disease, it is actually causing a systemic effect. And there is a lot of changes in the immune landscape, not only in the kidney, but in the systemic landscape as well. So that probably explains the increased risk of infection that you're seeing in these patients. So that kind of takes me to the summary of my talk. So the injury repair proximal tubules and thick ascending loop of Henle both play an important role in AKI to CKD progression. Inflammatory macrophages and lymphocytes, we know from before, and more recently, natural killer cells have been shown to mediate propagation of fibrosis. Negative urine biomarkers, high urine epithelial growth factor and uromodulin are negative predictors of AKI to CKD progression. Preclinical studies show promising benefit from ETA, endothelin A antagonism, as well as inhibition of HMGB to protect from AKI to CKD progression. Some suggestive database-driven clinical data indicate post-AKI initiation of SGLT2 inhibitor may prevent progression of AKI to CKD. Definite confirmation will require randomized controlled trial. And in terms of mechanistic studies, what holds the most promise in terms of future clinical testing and all that is ferroptosis inhibition, maybe something that may hold the future for preventing the progression of AKI to chronic kidney disease. So I'll stop here and I'll show you this picture, which is actually, this is my walk, in Indian Institute of Science. And these are like beautiful Gulmohar trees and, a lot of science buildings on either side. And it's a very beautiful and inspiring campus. You must visit the Indian Institute of Science. And this is the Indian Institute of Science Medical School that is coming up. And 40% of the building is already complete, and we should have 832-bed hospital ready by January of 2025. We are recruiting outstanding faculty to join our program in not only nephrology but various specialties. Please pass the word of mouth, and we'd love to consider. Thank you.